Well, welcome and thank you for joining this session of the All-Party Parliamentary Group on Social Work. This is the first evidence session in our inquiry into the integration of social care, which will be looking at how health and social care systems can be brought together to improve outcomes for patients and support practitioners. This is an enormously timely issue, with the government proposing a major programme of integration under the NHS Care Bill, which was introduced to Parliament yesterday, and that was recently consulted on in the white paper. This will be a major reorganisation of the health and care sector, bringing existing NHS bodies together into the new integrated care partnerships. There will be two more sessions in this inquiry in September, when we're going to hear from organisations representing the users of social care and the social care workforce. I'm very pleased today to be joined by my parliamentarian colleague, Paul Bristow, who's from the Health and Social Care Select Committee with me. And we're going to be joined in a little while by our colleague from that committee, Sarah Owen MP. Today, we'll be hearing from practitioners in the social work sector. So I welcome very much the people that have been joining. First, let me introduce Maris Stratoulis, who is the National Director of England for the British Association of Social Workers, a role that she has been in since 2014. As well as providing the secretariat to this APPG, the British Association of Social Workers is the professional association for social workers in the UK and the voice of its members. Welcome, Maris. Next is Mary Buckman, who's the Associate Director of Social Care for Oxford Health NHS Foundation Trust, an integrated mental health and community health trust providing services across Oxfordshire, Buckinghamshire, Bath and North East Somerset, Wiltshire and Swindon. Mary is the co-chair of the BASW England Mental Health Specialist Interest Group, and she has been a mental health social worker since 1998 and has worked within integrated health and social care services throughout her career, both as a practitioner and a manager. Pete Felden is the chair of BASW England Adults Group. His particular interests include people's experience of accessing the care and support system and the role of social workers in applying legal rules. He is also a freelance author and trainer specialising in the Care Act. Caroline Bald is a social work and human rights academic researcher with 20 years practice experience in adult criminal justice social work. Her research focuses on social work, education, the collateral consequences of criminal records, acquired brain injury, and multi-agency working. She's a trustee for the Working Chance and Mental Health Time for Action, as well as being the chair of the BASW Criminal Justice Group. And as I say, we're going to be joined by a couple of my colleagues. Paul Bristow is with us now, and Sarah Owen MP is going to be joining us, I think, sometime around about 4 p.m. So I'm first going to ask each of our witnesses to make some brief opening remarks, and then we're going to move on to questions from the panel. So can I ask you to kick us off, Maris?
Thank you very much. To begin this session, there is absolutely no way to ignore the devastation of the impact of COVID. There has been a disproportionate number of deaths of people from Black, Asian, minority ethnic backgrounds, adults with a learning disability, older people, particularly in residential care, and autistic adults, data of which is still being collated in more detail. Social workers are integral to the social care system. They support people in communities in diverse contexts and environments, people with additional needs and complex needs. Adult social workers have a range of roles to enable people to live and thrive within their communities, to draw on strengths and connections, overcome barriers and access support. Social workers take a lead in enabling people to make decisions, including when they may not have capacity to make particular decisions. Social workers are involved in the protection of adults from abuse and neglect, and primarily also promoting well-being. The role is not just about statutory responsibilities and functions. There are many settings where social workers are already working closely with health agencies, including mental health trusts, hospital discharge teams, as well as GP practices. Social workers have frontline experience of partnership working and can provide insight into the challenges faced with integration of services, as well as how we think it can best work. social work ethics and values are built upon a foundation of social justice, respect for diversity, drawing upon strengths, family and community connections, upholding human rights, overcoming barriers and obstacles, but primarily seeing the person as a whole person and the importance of their identity and local place. During the pandemic, our members have shared concerns about ethical challenges and practice regarding human rights, freedoms, choice and informed consent. One example of our Discharge to Assess survey, a comment from one of our members, highlights as follows. The Discharge to Assess model at times has encouraged the medical model of taking and thinking and driving health professionals into a, quote, respite care home mentality for discharge. Hospital social work is not just about beds. And the message in terms of the medical model at this point in time, overriding other models is an area of concern. First, what England supports the principles underpinning integration, working in equal partnership when it comes to social care and our health services. We support a model of integration that recognises the unique contribution of social work and the social model of disability and care. We want to ensure that social workers maintain an independent professional structure and identity, and that the principles of social work will not be lost or diluted in any way. This would need to be clearly reflected in the governance and structure of integrated arrangements with a shared purpose to achieve parity of esteem across funding, workforce, leadership, and decision-making arrangements. And this can also not happen in isolation of long-term reform of social care. Thank you.
As usual, I've muted myself because there was a bit of background noise. Mary, could you introduce yourself? Thank you.
Thank you, Chair. Many thanks for the opportunity to speak to the group today. Firstly, I'd like to talk about my experience as a mental health social worker of working within integrated services for the vast majority of my career. As a newly qualified social worker in 1998, I was working as a mental health specialist in a local authority team, and my first year in practice was characterised by the move towards integrated services and discussions about what this might mean. Integration itself was rather an iterative process. We started with co-located but separate teams, then to joint teams, but with separate filing cabinets with different coloured paper files, then moving to long-term secondment arrangements into the NHS as part of formal partnership agreements. And now social workers are often directly employed by the NHS, sometimes still delivering the council's statutory functions under partnership arrangements, but not always. Under these arrangements, I worked as a practitioner and as a manager of integrated teams, then as a service manager responsible for a variety of health and social care services across geographical areas. Over time, what I experienced was a gradual blurring of roles between the different mental health professions within multidisciplinary teams. The focus became the functions we were delivering, generally under the care programme approach to assessment and care planning. In my current role, which in itself is a demonstration of the commitment of NHS Trust to employing and supporting social work as a profession, I'm very much looking to support social work practice within wider mental health services, being clear about our professional identity and what we bring to what is inevitably often a medically dominated model of practice. Given that mental health social workers and mental health functions within local authorities have worked with integration in one form or another for over 20 years, it's important to learn from our experience. The challenges at different layers of practice, from a strategic level of how to demonstrate quality to a local level where practitioners are working with people, their friends and families and people who care for them within our communities. As social workers, we're always mindful of the context in which we are practicing, our responsibility to work with people within their individual systems with relationship and rights-based practice, identifying and working to counter the impact of social determinants of health. What I'd like to also emphasise is that social care exists in its own right. It can often be seen through the lens of supporting the NHS, particularly in terms of acute inpatient capacity. We can sometimes lose sight of the value the profession brings in its own right. We also can't get away from the reality of working within a context of competing financial limitations. Any discussions about integration needs inevitably to consider how to avoid the apparently never-ending requirement to categorise a person's needs as health or social care to determine which organisation is responsible for meeting those needs and funding any services. Thank you.
Thank you, Mary. Can we come to you, Pete, for your opening remarks, please?
Okay, well, I'm going to focus on what we refer to as the adult area in social work. So that's older people, people with disability, people with learning disability, but not mental health. I'm going to refer specifically to the Health and Social Care Bill. I was going to touch on broader issues of social care reform, but I won't do that in my 3 minutes. Perhaps we can touch on those later. I've always been particularly interested in integration at a community level, in the community setting, because when I started out in social work as a trainee social worker back in 1971, we were integrated with health. Health visitors and district nurses were employees of local government and were so up until 1974. So I worked in an office with health visitors, district nurses, and indeed my union rep was a health visitor. So what's the point of integration for social workers? For us, I think it's a more holistic approach to meeting health and social care needs and improving well-being. People experiencing an approach that is not driven by health needs and dominated by doctors and nurses. Better integration of social work, I think, will give added weight to the other professions in the NHS, therapists, dietitians. Looking at the Health and Social Care Bill, I'll just touch on hospital discharge and also the new responsibilities for the CQC. I mean, everybody agrees that people shouldn't stay in hospital longer than they need to, but we've got serious concerns about the recently developing discharge to assess approach, which indeed is endorsed by the bill. In some ways, it's going in the opposite direction of a holistic approach because it focuses on health needs and in a sort of fairly narrow way. It's risk averse, it overrides individual rights and preferences. In many ways, it's counterproductive by not focusing on enabling people to regain independence and doesn't make good use of individual resources, family resources, and resources in the community. This is in the explanatory notes to the Health and Social Care Bill. The references, I think, many of them are inaccurate and partial, and I can touch on that later if you have questions. Finally, just on the CQC then, we hope that the new responsibilities of the CQC to assess performance in relation to local authorities' application of Part 1 of the Care Act 2014, and Part 1 is the section that refers to care and support assessment, care and support planning, safeguarding, independent advocacy, etc. We hope that this will shine a light on good practice as well as addressing poor practice. Thank you.
Thanks, Pete. Thanks very much. And finally, Caroline, if you could make your opening remarks.
Thank you so much. So hello, and thank you for the opportunity to share evidence as a BASWA member. I'm a lecturer in social work, having been in practice for over 20 years, qualifying similarly to Mary in 1999, before working as a social worker in first probation and then youth offending, before becoming a social work lecturer, now with responsibility for a master's in social work with human rights. Central to my career is multi-agency working. So initially it was through MAPA, so multi-agency public protection arrangements, and leading the rollout of Violent and Sex Offender Register, so VISR. It was about working together together we were stronger. Joining our differences added value, and worked where starting from partners and in partnership was a given. And this was something that I really wanted to stress today. So in terms of integration, what does that mean in terms of partnership? There is so much that I wish to share today, and I will keep it brief, I promise. But my hopes fall into 3 key points. To frame these, I think it is worth revisiting what social work means to me, and what Professor Marmot considers an urgent need in his revisiting his 10 years report later. I will contextualise my 3 points in what I'm up to now, what I'm doing in my work, and my work is specifically in Essex. And for those who don't know Essex, part of the working area that I'm looking at is Tendring District, specifically Clacton and Jaywick, where I'm involved in a whole community approach, which is really innovative in addressing gaps in social determinants of health. So to come to the quotes that I wanted to share, so Professor Marmot, if health has stopped improving, it is a sign that society has stopped improving. And I think that's where social work and health could really do dovetail together, and us coming together more formally will hopefully help that. I also want to come to the broader church of social work, if you like, and quote the International Federation of Social Work's definition of social work. So social work is a practice-based profession and an academic discipline, and provides and promotes social change and development, social cohesion, and the empowerment of liberation of people. So principles of social justice, human rights, collective responsibility, and respect for diversities are central to social work, underpinned by theories of social work, social sciences, humanities, and indigenous knowledges. Social work engages people and structures to address life challenges and enhance well-being, and that it will be definition that should be applied nationally and at regional levels. So my argument is that there is a vital contribution of point of difference that social work brings. So to my 3 key points. The first, communities. If nothing else, the pandemic has shown social inequalities impact on health and life challenges irrespective of age. The 2 million people estimated to be affected by long COVID, the time has come to reframe healthcare, health and social care, to recognise lifelong care needs, revitalise communities, roll back defunding of early intervention, and support the rebuilding of community assets in and with communities. And that's something that we're doing in Jaywick and Clacton. My second point, creativity. The first point is to remind of the legal obligation for the prioritisation of parental health and well-being, including support for addiction and mental health as a broader issues of health. Social work as an agency works between and with agencies, such as health and criminal justice settings, for example. The new Social Work in Prisons project led by PACT on Lord Farmer's recommendation, and a piece of work I'm involved in brain injury social work, we're now increasingly aware that women risk brain injury as a result of domestic violence, often going underdiagnosed, leading to distress and what we now know to be overrepresentation in prisons. So with UK Acquired Brain Injury Forum and the police, we're centering social work's unique contribution, including to community development and co-production, in working together to form a better solution that we argue will actually be more cost effective, because we're starting with the people in mind. So I ask that social work be given equal space at the decision table when it comes to granting research fundings. We see opportunities to address health and social care needs better together. And finally, coming back to my home as social work education, I'd like to reinforce connections. I would like to flag how vitally important it is to focus social work education specifically as part of this review on this integration. We know life is not linear and people do not live in isolation. So it is illogical to separate child and adult social work education from the outset. That makes no sense. By working with people, families and communities, we can better address complexity and commonality of need and aspirations. And by leaving social work education in order to consider lifelong needs, I argue is a better way to maintain health and social concerns and focusing on the social predictors of inequality. So thank you very much.
Well, thanks to all our panel. That was really helpful, and I'd like to move into the questions. At the moment, there are just two of us parliamentarians here, so I think, Paul, if you're okay, we can alternate questions. Let me kick us off by asking the first question. If the panel can talk us through, from your experience of the integration of health and social care so far, and I think a number of you touched on that in what you said, clearly there have been times when teams have been integrated, as Pete referred to, and Caroline has talked about her work being integrated in teams like MAPAS teams. Do you think the integration we've already seen is delivering improved outcomes for patients? That's the first question I'd like to put to you. Maris, would you want to start us?
Yeah, I'm happy to start, Barbara. I think there will be an evidence base around that, and particularly at a local place level. So, for example, if we look at the model in terms of Salford, in terms of Manchester, and some of the ICS models as well, I think there's been great strengths in terms of partnership and collaboration work. But I would also advocate that that is very much based on relationships. It's based on governance structures. It's based on people respecting the unique contribution of different people at the table. And that includes social workers, and the governance structure with social work are increasing concern. And we want to make sure that this is right for citizens. We want to make sure any integrated model is successful in terms of improving outcomes for citizens. And certainly in terms of the work that we've been doing on another campaign area, which is called Homes Not Hospitals, the messages from carers and people with lived experience to us is about a joined up approach from partnership organisations, but about treating them as an individual in their own right, not as somebody who's got perceived designated illness, not as somebody who's got one perceived social issue or social determinant, that directly affects their health. So it is about the collective model does improve, I think, outcomes for people, but it's about relationships. It's about acknowledging the unique contribution of health workers, of therapists, of social workers, of pharmacies. It's about the communication, the effective impact of communication. But at a strategic level, I would say, and I think there is an evidence base, and particularly when you look at the development of some of the early stages of ICSs, is that we've got to have social work and social care at the table. We cannot ignore that. And my concern is that a number of integrated models are calling themselves integrated, but the dominant focus and the dominant model is health. And that is not holistic, and it's not joined up. That's my personal comments. It'd be really good to hear from other panel members.
Thank you, Maris. Mary, can we have your thoughts on this question?
Yes, of course. Thank you, Chair. The short answer is it can do. Yeah. And I think I'd say it depends on the models of integration, the governance structures, as Maris has referred to. And one of the things that comes up time and again when we're looking at integrated health and social care within a mental health context is role clarity. So what do the individual professions and organisations bring to the table? What are we there to do? Because there's a risk that without that, we end up in a generic single service. We just happen to come from different professions, and we happen to come from different organisations, but we haven't clarified what our functions are within that integrated service. What is it that we are bringing to the table? How is that governed? How is that set out? Is there clear agreement on that? And also about there are partnerships and integration, and there's a risk that local authorities can feel like a junior partner, that social care doesn't have the profile that health does. And one of the things that has often happened and led to previous integrated models of health and social care breaking down, and many of them have over the years, is where local authorities feel that local authority resource is being used for health tasks. It gets back to what I was saying in my introduction about we tend to think of things as health or social care as separate things. That's where how does the money flow into the system? Who's responsible for managing that? How is that determined? Because otherwise we default to, this is social care money, this is health money, this is what we use it for. And we can't get forward to thinking about properly integrated budgets, because not all integrated budgets are properly integrated. We still have discussions within those systems around the health bit of the budget and the social care bit of the budget. So that issue, we need to grasp that nettle really about health and social care budgets, where the funding comes from, who's responsible for something, and the role clarity issues. But I think partnerships done in the right way and integrated services delivered in the right way can only improve care.
Pete, can I come to you?
Yes, we're sort of looking at it from the perspective of the long view. I mean, integration, we call it now. I mean, back in the 90s and the noughties, it was trying to create seamless services. Before that, we worked together. We've always worked together closely, and yes, of course, very closely. Back in the early days of social work, so it's had its ups and downs. I mean, it works. There are touch points. I mean, for me, there's risk and money are some of the touch points. The culture of many of the health colleagues is social workers' experience as being risk averse. So when it comes to discharging people from hospital, often there's a culture of risk averseness in people who particularly are hospital based, less so those are community based. And it's overcoming that divergence, often, as other people have said, through good relationships on the ground, and to some extent through clearer structures, which the Care Act, I think, has brought to the table with its clarity on assessment and care and support planning. But there is the tension, I think, alluded to by Mary, around funding, around money for individuals. That's a particularly a sharp experience highlighted by the discharge to assess, where people are being discharged into with a particular care package funded by the NHS, free, and then receiving the same or almost the same care package once they pass over into the hands of social care, for which there is a means test. And that's an issue of tension between, not so much tension, it's an issue to be managed between health and social care, sometimes well, sometimes not so well. And again, it depends on the relationships and the way in which it's worked.
Okay, thank you. And Caroline, if we come to you on the first question.
It's a really interesting question, so thank you, Chair. I'm going to borrow off Mary, if that's okay, that it could. And I think if you look at any of the reviews into anything that's gone wrong, often one of the common threads is communication. And multi-agency working in itself, I've been blessed to work in the most collegiate together approach to risk management, but I've also been in situations where there's disagreement, and where there's disagreement, that rubbing point, it really does come back to culture, and the culture that we each add value, that no one service is more important than the other, depending on how you might feel at the time, and that actually together we're stronger, comes right back to it, and that's at the basis of it. And I think money is part of it, and I think when you really are having to make sums add up that don't add up, it's very easy to prioritise, say, policing over housing, and I'm not having to do those sums myself, but I do know where it has worked is where there's an agreement that you're also part of the table, you're at the table. You may be the smaller partner, but you actually bring something particularly here that we don't have. And that is something that I experienced in my own multi-agency working. So for example, if you look at tendering, it is across health and across the sector with education, housing, and it's a whole community's approach. And what I've noticed in my house and my health colleagues is that what they do bring is a real structure to how we're proceeding. What they are learning from us, or what they tell me they're learning from us, is also about how to work with co-production and the messiness of working with lives, because it really goes from A to B without bypassing D and E. And so what we bring together is clarity, a structure, but also a recognition of the messiness of life that it brings. And only by us being in the same meeting and being able to share the same loudness of voice, for want of a better way of putting it, does those messages come across. So where it works really well, and it has an impact on health immediately.
Thank you. Can I throw this over to you, Paul, to ask the next question, if you will? Next question.
Yes, thank you, Chair. And we've heard 4, I think, very impressive contributions from the panel. And what I'd like to ask, and I know you've answered this question in part through your initial contribution, but if there was one message, and I always like to kind of clarify things and kind of very simply, if there was one message about integration you would like the government to hear, what would that be? We'll start with is it Maris first, and then the same order as before, perhaps.
I think my message at this point in time, Paul, being really honest, is respect for the value of social work and what social work can actually bring to the table and social care. And I think that sadly is missing and has been for some time. And I think that's been played out in a political narrative in the last 16, 18 months, to be honest. So I think there's something about respecting the unique contribution of social work, and also acknowledging that we're part of the bigger picture. So social workers are part of integration that can make that difference, and we have been for a long time. And I know I'm probably going on beyond one point, but the other thing I'd really like to say at this point is, even within the Health and Care Bill, that the actual structure of ICSs, and you're going to have the Integrated Care Board, and then you're going to have the Integrated Care Partnership. My question to government would be, why do we not have a governance structure of local authorities or local government that are integral in terms of the governance structure of the Integrated Care Boards? Because at the moment, it looks as if it's focusing again specifically on health, but yet it will be looking at the wider determinants, social determinants as well, that affect health. But respect and value and contribution of social work.
Can we come to you?
Thank you, Chair. I think I'd pick up the issue that I did touch on in my introductory opening statement, which is that social care and social work can sit independently from health. And whenever we look at integrations, that narrative is often that social care is there to support health capacity, particularly in terms of discharge planning. It's our role as social care to get people out of hospital, keep people out of hospital, and it's about care packages and placing people into care settings. And whilst they can be functions that we do, I'd like to say very well, that's not all of what we do. We're there to support people within their communities. The Community Mental Health Framework, which is currently being implemented, talks about place-based care and the role that we have to deliver care and support to people within their communities, within their home circumstances. So, you know, what we do can be preventive in terms of health needs, and it can be supportive in terms of NHS capacity, but that's not all that we do. And it needs to be set out quite clearly. Sometimes health can support social care. And there's a risk that whenever we talk about health and social care becomes the afterthought and the supporting afterthought to health.
Yeah, I guess for me, given that there's going to be changes to the Care Act around hospital discharge, it's an opportunity to make improvements about the way in which assessment and care and support planning is undertaken to make sure there is a good understanding within health about the differences between assessment and care and support planning. Often, and this is exemplified in fact the explanatory notes, where there's reference to hospital discharges being delayed because of delays in assessment, which is wrong. There are very rarely delays in assessment. There are delays in care and support plans being formulated, but there's never delays in assessment. So it's an opportunity to get that right. And in some ways, maybe even, it's probably a little ambitious, but to say, well, how can that be? How can joint assessment, integrated assessment, coordinated assessment, the Care Act, or rather the statutory guidance for the Care Act, uses all those words. How can they be improved? And the ambitious part of me is saying, well, with regards to leading on integrated assessments, leading on joint assessments, I think that social workers are best placed to do that. Social workers understand health much better than health understands social care. So give social workers the lead on joint and integrated assessments.
Good thought. And Caroline.
Thank you, Chair. Similar to my colleagues, I suppose when I heard your question, I see what came to mind was partnership, not takeover. And I think the reason for that is, I go back to what I said earlier. Professor Marmot is saying that if health has stopped improving, we need to look at society. And social work is about society and where people sit within society. And what we know, again, to revisit some of the evidence I've given, is that when we work together in terms of research, we're actually far stronger in terms of providing evidence to Parliament. So, for example, around the domestic violence discussion and the recognition of strangulation as a specific area of cause for concern, that came from joint working. And I think it's about bringing people together as in partnership, truly, with a reminder of it being a partnership. And if that is in legislation or funding, so be it. But that reminder, it's a partnership, not a takeover. And I think I would also just reiterate what Maris was saying there about local authorities. And often local authorities can very much feel like the poor relation. I think Mary also mentioned it, that poor relation. And I would certainly like from an integration, which is quite a harsh word in itself, I would love the opportunity for local authorities to really take the lead in what their local communities need in terms of researching themselves and learning from each other. So there are huge opportunities here, but for me, it comes back to the principle. So the starting point, the messages that are given from yourselves about why this is needed. Thank
you. Well, I should say, I think we've lost Paul momentarily, but I'll come on to the next question. That was very helpful set of thoughts. Next question is really, what are the main challenges and obstacles facing the integration of NHS and social care? And I think we've touched on these, but perhaps if we just explore that question a bit more. Can I start with you, Mary? Just so we're not always in the same order.
I think culture. I think the culture within the NHS and the culture within local authorities, we shouldn't underestimate how different they are. So when we are talking about integration, we need to, it is understanding what is it we're trying to achieve with this integration, and this integration, and why are we doing this? What's the ultimate aim? What is it we're trying to achieve? Because if you don't set that out, and you've got these pre-existing and very clear cultural differences between local authorities and NHS organisations, then you end up starting from a point where there isn't real understanding of what it is we're there to do. And then people get back into their own bunkers, they get back into their comfort zones, and they still think about, well, I'm here representing a local authority and I'm here representing an NHS organisation. And that's how the whole process can move forward, without people thinking, when we're in this room, we're here in an integrated way and we're trying to deliver a single, very clear shared aim. And if you don't have those things, I think you might be calling it an integrated system in some ways, but it's not truly integrated. People are still thinking about where they've come from rather than what they're doing now.
Thank you. And Pete, can I come to you this time?
Okay, yeah, well, sort of two things for me is yeah, culture and budgets. So echoing some of the things that Mary said, yeah, well, there are cultural differences, but how can they be overcome? I mean, there are lots of initiatives, of course, in terms of building relationships, but yeah, I mean, it can, if it can be addressed in terms of joint training, that's an opportunity where people can look at issues in a more relaxed and considered context. So in relation to hospital discharge and in relation to addressing the issues of the different cultural frameworks for risks, those can be addressed, and in some way, if they could be, well, if not a requirement, but if there could be some good models of joint training identified perhaps by the CQC, can shine a light on those and can recommend that they be rolled out across the country. In terms of money, well, and this touches on social care reform, I guess, maybe it would be, maybe some of the obstacles would be overcome if people experienced social care more similarly to the way in which they experience health, i.e. there were elements of it which were non-chargeable. So certainly in terms of social care reform, looking at budgets, we hope that the government will at least be strongly considering free personal care. I think that would help to overcome some of the barriers.
Okay, thank you. Something I very strongly support, so I hope so too. Caroline, can I come to you?
Yeah, thank you, Chair. So I would say that of all the things you can choose, I think there's two things that stand out to me. One is language, and the other is the enormity of the task at hand. And I think if we can address language, I think it will help us get together to actually deal with the enormity of the task. And language, for me, is, for example, key leaders not using language in relation to social workers, such as wading in or runaway train. I think that does huge damage, not only to the impression of the service, but also to those families that receive the service and colleagues who are actually in the field, as it were, doing the job day in and day out, including, you know, weekends and all sorts of hours. I think that was deeply harming. So if we can have language that, you know, we've just celebrated the NHS. I'm not taking anything away from that, but I think we also need to recognise the language needs to be extended to social care colleagues and social work colleagues, so not to the exclusion. My second point is the enormity of the task. So in the area that I was mentioning earlier, tendering, in a small area of 145,000 people, for example, one area of that has the lowest life expectancy of all of Essex. So that's the South Tendring, has the lowest life expectancy of one of the largest counties, if not the largest populous counties in the UK. And so when you think about the enormity of the task, I think there is an opportunity here for us to really truly get together. But it starts with me, an honest recognition that perhaps up to now we've not seen health and social care, but actually the joining of the two shouldn't be a taking over of the one. And that's something that I would certainly stress if I was able to.
Okay, thanks, Caroline. And Maris.
Thank you, Chair. Building on the points that have already been stated, I think I'd like to highlight brave system leadership, and that's about people understanding the challenges that exist in different organisations from a financial perspective, from a policy reform perspective, and the importance of understanding, again, roles, remits, areas of responsibility, the sense of place, the sense of community. And in terms of brave system leadership, I also think very strongly it's about having people with lived experience at the table as well. And that's across health, across social care, across housing, police, a variety of integrated organisations. It's making sure that we really understand what is happening at a local place, but also individual experience and community experience. And from a system leadership perspective, it's also about people being brave enough to give up what may be perceived as elements of power, of decision making, and how can that be embraced in a more collaborative approach to ensure that outcomes are met for local people at a community level.
So I think it would, just to say, we've got just 40 minutes left. So we've been asking panel members to answer each question. We may not get through all the questions if we do that. So don't feel that we have to carry on with that. I think if there are things you agree on, I think just perhaps if a couple of members answer each point really. But the next question really is about what action we need to see from central government to ensure that integration delivers positive outcomes for patients and practitioners. There's a real fear, I think, about doing this piece of work at this time, isn't there, nationally? That, is this a time in this point in a pandemic to be rearranging anything in our health and care systems? But what could we see from central government that ensures that the integration we develop or that has developed delivers positive outcomes? Does anybody want to start us off on that question?
I've got some immediate, sorry, Pete.
Yeah, either of you.
I have some immediate thoughts, and then I'll hand quickly over to Peter. So for me, there's something about the recognition of the social determinants of health and the wider impacts of health. We're not just talking about a medical model of treatment. We're only hearing today about decisions about universal credit levels. We're hearing about housing issues, and you can't look at whole population health without acknowledging the wider impacts of those concerns about we need good employment, we need a welfare system that provides an appropriate level of support so individuals and families and communities aren't living with poverty and the impact of poverty, and that we can't think about that without thinking about housing and good quality housing in the right place that's affordable for people to stay and live within their communities. So there is something about we shouldn't just be looking at a health service as a treatment service. It is around looking at more whole population health.
Come in next?
Yes, please, yes.
Yeah, I think, Barbara, it is a time where we can be ambitious. I think the impact of COVID has loosened things up in many areas, and as well as the integration, we've got social care reform, hopefully on the agenda sometime soon. So it is the time to address some of the bigger issues. And maybe one of the issues is to, in terms of integrating health and social care, is to no longer talk about patients. We used to talk about the people that we worked with as clients. We don't anymore. We talk about people with social care needs. We talk about people with particular disabilities. We talk about people, sometimes we're referring to them as people just with lived experience. But maybe now is the time to develop, to assert that there ought to be a common language across health and social care, and a language which we can all agree on. So we're not going to talk about patients, we never do. So let's talk about people in another way, in a way which doesn't ascribe a particular health attribute or indeed a social care attribute to them. So I think let's have that debate. And also, I guess we can't control the media, but let's try and control the media and stop them referring to Sajid Javid as the Secretary for Health. He's the Secretary of State for Health and Social Care. He's not the Health Secretary. They often miss that point. But we need to pick them up every time they do that.
Thank you. Caroline and Maris, do you want to add?
If I could
Caroline first.
Sorry, thank you. I'm running away. If I could add just a little bit about education and my concern for education, and I think from central government there seems to be a particular concern about the quality of education right across public sector education, professional education. So we saw at the beginning of this week announcement around the teaching education. And there's sort of there are reviews into other aspects, and I think probation education, for example, has gone out for market testing. My concern about that is it sets a narrative that current education isn't fitting the bill, which worries me a great deal. But also it in disrupting at this particular point, I think it's one of those waves that when you make the disruption now, the impact of that comes years ahead. So having lived through the experience of criminal justice being removed from social education, I have seen in my 20 years criminal justice becoming other, so that you lose that integration. So what started out perhaps a good idea has become something that actually is excluding. And so I would just have a plea that while it's based in universities, it's also part of health and social care to recognise that to value our students is valuing our future nurses, social workers, and those teachers who are encouraging pupils to consider these types of careers. So I think these are big messages that really need to go back, in my view, to the Department of Education.
Very much so, and I think we really relied on students, didn't we? I think students were dragged out of every corner of every building during the
They were
first part
desperate.
of the pandemic.
Yeah, absolutely. They came to me before I'd even thought of it. What can we do? And that says a huge amount.
Very much so. Thank you. Maris, do you want to contribute on this question?
Yes, I would actually. I'd just like to expand in terms of pace. And I'm really concerned about the bill being laid before Parliament yesterday. I think the concerns about real proactive engagement with partnership organisations, with practitioners, but also with citizens. And my concern is that that voice will not be represented. And when you look at the bill, and I'm only about halfway through, I'll be totally honest, I think the language, the terminology, the nuances, how is government going to ensure that there was a really inclusive process of engagement with the citizens of this country, as well as staff and leaders across organisations, across partnership organisations that are directly involved in integration? And I would certainly welcome, where is the easy read guidance? And I really mean that. How are we truly going to engage with citizens in this big piece of reform? And so I would request pace, I would request time, and an approach that is truly inclusive.
Thank you. I think it would be worth just my putting the question. Are there any areas within your profession, or the social work profession, that any of you think will be particularly affected by integration? I mean, clearly integration is going to have impact. So either, things that could improve, or things that you're concerned about. And we've touched on some of this already, but if we can answer that question. Any particular concerns? Caroline?
My concern is more of a flip positive here. My concern is that we don't take from the outset in not addressing the language I mentioned. It's the opportunity for cross-learning and interdisciplinary, and maybe coming out of our silos all the more. And I take the point back to Maris's point. It's about brave leadership, and it's not about power silos. It's about we cross the line together. And I've certainly appreciated, just on my own personal level, occupational therapists, speech and language therapists coming to talk and speaking and cross-learning between different students groups. They shouldn't meet each other for the first time when they're out on a ward. So if we could not miss this opportunity through maybe the bureaucracy or the pulling together that takes the focus away from the opportunity, that to me is the risk and also the win. So the win for me is it's about if we really pull out of it the opportunity to move forward together, which I have to say is happening in pockets. So perhaps Mary.
Mary?
Yeah, shall I pick up from there,
Yes.
Chair? And I'd agree with Caroline. And as I've already described, I've spent my career working within integrated services and very much trying to make integration work. So there's a lot about this that's actually really exciting, and it could be great because it could address some of the challenges that have been experienced over the years in making health and social care integration work successfully. So if it's done properly, it could really be empowering for professions working within a structure where everyone's clear about what their role and function is. And as a whole, we're greater than the sum of our parts. You know, I know it's a bit of an old chestnut, but I think it really works here where you've got a really good functioning multidisciplinary team where you've got different professions working together, all understanding and respecting each other's roles. We deliver a better service, we do a better job, we enjoy our work, we feel as if we're really adding value. But it's getting back to leadership and structure and really being clear about what the goals of the integrated service are and how we're all working together to achieve them. But personally, I find it really exciting, and I think it could have a really positive impact if it's done right.
Maris or Pete?
Yeah,
Again,
yes, please. I agree with Mary's points absolutely, and what's been said previously. I think where I do have concerns, and this may not be shared by all panel members, is that I am concerned that the specific role of social workers in particular contexts could be diluted, or those roles could actually disappear. And when we think of hospital social work, and I'm not specifically focusing in terms of mental health, but in terms of, for example, adult wards, and the way that social workers were previously involved in really working very closely with people in terms of making decisions about their discharge, about ensuring informed consent, I'm concerned that those roles could potentially be minimized or disappear in the longer run. I hope I'm proven wrong, and I constantly say that the value of what social work brings to the table is paramount as part of an integrated approach. But I am concerned also with local authority pressures in terms of funding streams, that there will be a polarization and a pullback of particular roles as well, where there has been an integrated model. And it's interesting, again, within the bill, the financial governance is very much sitting with the integrated care boards. And although it says that, part of their duty is to have regard for the wider effect of their decisions, again, we've got to make sure that the views from the social perspective and the well-being of citizens is incorporated into those governance decision-making models.
Pete, thank you. Pete, do you have anything you want to add?
Yeah, just one small point. Well, is it a small point? Hospital discharge. I mean, the new model is that, as it is at the moment, there is a prescriptive approach via what's set out in the Care Act and the recent developments in discharge to assess. They are relatively standard in their approach across the country. What's being proposed is that each locality will be able to develop its own hospital discharge, approaches to hospital discharge. And I suppose on the one hand, there's anxiety about that. I mean, in one way, one welcomes the removal of the prescriptive approach, but on the other hand, if it's down then to each locality to develop its own approach, a bit of an anxiety about that. I guess the intention is that the CQC, in terms of its new role, will be looking at each of those approaches, and ultimately will come to a view, those that work better than others. But there will, I guess, some approaches will be better funded than others in some localities, and that is a concern.
Yeah. I mean, going back to, clearly as we set out on this journey, as much as I understand the tensions and the challenges, if we're thinking about the main benefits of integrating health and care from the point of view of improving outcomes, I want to ask you, do you know, are there places in the country where these benefits are already being realised? I think, Maris, you mentioned Salford earlier, which is my local authority. It'd just be useful, I think, to think on that question for a moment or two. And we're just being joined, I think, by my colleague Sarah Owen. So yeah, any places in the country where the benefits of integrating health and care are already starting to help with outcomes.
I think it's you know, some of the models have been highlighted in terms of models of good practice, the experience, that there is less of a revolving door, which is what we hear about constantly, people not having to repeat their story, but also at a community level and at a recent meeting that I was present at, somebody rightly said, a person who's in receipt of services, they don't care actually whether it's a social worker or a health worker or a community pharmacist that's involved in their care. They want an improved outcome for themselves. They don't want to be telling their story 10 times over. They don't want to be fighting and advocating for services when they can be having somebody as a coordinator lead who's actually doing that work for them. So for many people, it's about that really personal experience, you know, that they're not always aware of who the person is actually representing, who comes to see them, being totally honest on what was shared with me recently. However, they are, you know, people are saying they want their voice heard. They want to be involved in decision making about their lives. They want people to understand that the impact of poverty, the impact of homelessness, the impact of their life experiences are still having an impact on their health. And these are where, as Mary has highlighted, the social determinants of health are really critical in local place as well. And that's about the modelling of how collectively can we improve outcomes. And I think there is an evidence base, but within each area, I would also say you will also come across people who are saying it's not working for them. In terms of receipt of services, you will have people who are saying it still isn't joined up enough and not understanding the language and the terminology of different professions. But I genuinely believe that there is an evidence base in some areas, but it's also about trust, it's about relationships, and it's about measuring outcomes for people. And they may be soft outcomes as well, the confidence of actually being able to go out the door again.
Thank you. Thanks, and welcome to my colleague Sarah Owen. Sarah, I'll come to you in a couple of minutes. We're just I'd gone back to a question, but we are towards the end of our questions. I'd gone back to a question about the main benefits of integrating health and care from the point of view of outcomes, and whether there were places in the country where the benefits are already being realised. So, Mary or Peter, do you have points you want to add on
Mary,
that?
she's got better on-the-ground experience than I have.
Okay, Mary.
I think I can talk about the current experience of the ICS within which I work, where there has been able to work across current boundaries, so working across a number of different authorities and counties and health organisations is really positive. To think about a wider community, I think that's really positive in terms of commissioning, in terms of bringing in different system leadership. But I think it's around we're back to parity of esteem, really, in terms of who's around the table and whose needs, which organisations' needs are driving things forward, and who's seen as the junior partner, maybe supporting things. And so it is about parity, and I think it's early days from my perspective to actually see outcomes coming through from an individual perspective receiving those services. It's too early days. But it is around thinking, what do we mean by positive outcomes? Who's determining what's a positive outcome, and who are we asking? So we're back to what we've said before about involvement, about proper co-production rather than consultation, but actually asking the population, what do you want and how do you want it? Because Maris is right, to a large degree, people don't care. As long as what they're receiving is good, they're being heard and they're receiving something that's helping them to achieve what they want to achieve, they're going to be happy with it. But if any of that isn't happening, if they're not being listened to, they're not receiving what they determine to be the right support and services at the right time for them, in the right place for them, then they won't be happy. So we do need to really think about co-production with local communities.
Thank you. Caroline, you have a point you want to add? I mean, you are already working in an integrated area, aren't you? So,
well, it's probably more integrated with a small I, and I think it's interesting that when you bring in structure to make things integrated, what added benefit do you create? And I think the added benefit is about that clarity of structure. So the integration of health and social care needs to also acknowledge, with a small I, that integration with education, that integration with employment, so job centres, colleges, schools. So, for example, in the tendering area that I'm working in, often what's missed is SEND education, so special educational needs and disability, and thinking as a community response to the adult autism strategy, is about recognising local innovation and creativity. So what we've managed to do is, by being in a room, and that to me is integrated, to create a space, we've got together rather excitable people thinking, how can we actually tackle the gross injustice of only a quarter of adults with autism being in full-time employment? So we're looking at creative ways. So that's a cross piece of looking at health, looking at education, looking at social work and computing. So I think, to me, innovation comes from integration of culture, language and space, but within a structure. So I would say social work is one of those professions that, it's challenging, but we do so much, often with very little, because of that commitment to creativity and working together. And I would say this, I've experienced similar from my health colleagues. So to work together in this way, there are pockets of excellent practice, but I've also heard, as we see today outside Downing Street, I've also seen where services shut down and they lock out families, such as Matthew's campaign today, and that call for a duty of candour to talk about when things go wrong. And I think that's where we're not necessarily that good at, if in all honesty. So I think if we can work closer together, I think that we can maybe stop protecting our backs and actually focus on the front and getting on with the job.
Thank you. Sarah, do you want to, let me throw it open to you.
Could I just add a point to
yes, of course, Pete,
that question, if I may? Yeah, I suppose just slightly looking forward, there will be, once the CQC's new duties are established, they will be looking at what is working, what is a positive outcome for integration. And so there will be a debate to be, well, there is a debate to be had, that what does a positive outcome look like? And that's something that we would want to ensure that we are engaged in that process with the CQC, and making sure, well, encouraging the CQC to take on board the perspective of people with lived experience in terms of looking at what is a positive outcome. And as I said, we hope that we hope that the CQC will be shining a light on good practice, something that is missed in terms of the application for social care, for the Care Act, because there is no process of inspection, there is no process of assessment. We rely on little bits of research, of which there is not much, and the local government ombudsman account of complaints to get an idea about what is going on the ground across the country. Hopefully the CQC will improve the amount of knowledge that we have about what's going on the ground. But as I say, there needs to be a debate about what does a positive outcome for integration look like.
Thank you. Sarah, we haven't come on to questions 8 or 9 that are on our list. So if you want to ask either of those or anything else that you want to ask.
Take myself off mute, that's always handy. Apologies for not being able to make the beginning part of the meeting. I came in on just as one of the panel were talking about having patients' voices heard. And what I wanted to do was just get your views on how we're ensuring that there's a diverse amount of voices that are being heard, and how we ensure that we are really reflecting communities in the care that we're giving, whether that's integrated or otherwise. And then and how we can best do that as well, if there are any models of best practice. And in terms of the health and care partnerships, how can it be ensured that the voice of the NHS does not dominate? I think that that's something, it's not just about the voice, but it's also about how funding will be distributed in future as well in an integrated health and social care setting. I don't mind whoever
Wants to start.
First, yeah.
Caroline's on too.
Yeah, if I could come in on that, because I'm interested in co-production, and also, you know, I think there's the phrase is co-production, not full production, and rather than me speak about how best to hear patient voice or people voices, we were wanting to shift the discussion. I certainly would recommend looking at the work of Professor Peter Beresford and his approach to how to effectively, so there are models out there on how to effectively connect decision makers with service receivers and the barriers to that. So I'm working, for example, on a piece of research where we absolutely see it as co-production, and that it's peer led. We've included in the budget ways to actually pay people for their labour, for their time. But I know that has a knock-on effect when it comes to maybe benefit entitlement. So there's ways and means, but again, it's about front and centering people's voices. You know, I've had the opportunity to come here today, and I'm going to leave feeling heard. And how do we make sure that we can take down some of the barriers to hearing voices right across the board? And I think if I would recommend, I'm happy to share with you or connect to you as well. But certainly the work of Professor Peter Beresford.
The bells are going and I have to vote, so I might just take you with me if you think it's a bit weird that I'm walking around around corridors, but I'm taking you with me. I'm not logging off. I want to hear your answers.
Lovely.
Thank you.
Okay.
Sorry.
Maris is waving and Mary's waving. Either Mary, do you want to? Shall I come to you next and then to Maris?
Yeah, I was just going to pick up Sarah's question about how do we avoid the dominance of health, and I know that's something we've touched on a little bit throughout the discussion this afternoon. But I think there is something around how the system leadership is designed. So who is it? If we have a single system leader, what background are they from? Who are they reporting to? How do we make sure that system leadership, when it starts there, has a clear idea that they're not there from a health perspective looking for local authorities to support them with the bits and pieces, but actually this is about health and social care working together to support whole population health and outcomes for the communities. So there is something about how the systems are structured in the first place and appointed to, and an understanding of where does the reporting go. Because otherwise there's a risk that we default to demonstrating performance and outcomes by widget counting, if I can use that term, by how many people we've seen, how many people have come through hospital, what's their average length of stay. We focus on those good old measures to show whether something is working or not. And I think if we do what we've just been talking about well, in terms of how we design what a good outcome is, and that's done through proper co-production, and then the system leadership is designed around, okay, how are we going to achieve that? That would be my initial thoughts.
Maris, I think you were waving, weren't you?
Yeah, just to add to that very briefly, from a co-production perspective, it can't be an add-on. It has to be integral to every governance structure, as outlined, within the Health and Care Bill. We've got to make sure that there is representation at all of those governance structures, and also citizens need to be involved in decision making about financial resources. Citizens know their communities best. They know and live their experiences. And it's really integral that anything that goes forward is that we ensure that the voice of citizens is at the centre of this, and the learning from citizens. And that will also inform outcomes that are defined. They have to be co-produced and led by citizens.
Peter.
Yeah, I mean, one of the things that looking just at the way in which social care works that concerns us is the lack of transparency in decision making where money is involved. Now, the Care Act brought about some considerable improvements. The focus to enable people to focus on the fact that many decisions are around money, with the introduction of personal budgets, and there is that, of course, the introduction of that in the health field. There are personal healthcare budgets, and that focuses people's minds on how decisions are made, and how there is the tension between what the individual thinks meet their needs, what's a professional judgment about what meets their needs, and what those who control the purse strings think they can spare or allocate. That's a better word. But that transparency is difficult to achieve within social care, but improvements can be achieved. And likewise, I think that's a challenge that we can embrace with health colleagues in a joint way, by looking again at the relationship between personal budgets and personal healthcare budgets.
Thank you. Well, Sarah, you've just given us a unique tour of the House of Commons, which is a very different thing in a webinar. So well done. I hope you
I'm
could
very
hear
sorry.
those.
I didn't want to.
No, it was fascinating actually. It's fascinating. Have you got a follow-up question?
I just wanted to have a quick. A follow-up question from Maris, and it's about, she said about the community and that link being integral. It's just, how do we cement that and make sure that that's the norm and not just kind of an added bonus, and that it depends on where you live and that kind of service that you're going to get. I'm refusing to use that well-known phrase, but how do we make sure that becomes the standard for people's social care experience?
I think it's a balance, Sarah, between some of it in terms of statute, but not in a tokenistic way. So as I say, and I've only started going through it, in terms of the bill and the reference to the integrated care boards, that seems a very health-focused model. Obviously, the partnership element of the ICS, includes potentially representatives from local authorities within the footprint of that area, carers and potentially citizens within the context of that community. We've got to try to practice base a structural level and a statutory level. And certainly I think in terms of the very sad evidence of what we've experienced through COVID, there has been communities and citizens within communities that have been incredibly isolated, excluded from support services, including as a result of the enactment of emergency legislation. We've had closed communities as well, where families have been separated. And if we're really going to make integration work, it is about remodeling inclusive engagement at a community level. And I think social workers have a really integral role to play here. They work within the context of communities and look beyond silo models. They are looking at community engagement, community development. So I would say it's about a practice-based model approach from an integrated perspective, involving citizens at a local level at first points of contact. It's about co-productive forums, and it's also about the ICS structures if we go down that route, and financial decision-making governance boards, where we have citizens present and not as a token, but really actively engaged. And BASWA has done some fantastic work from a co-production level. We've had carers, we've had people with lived experience shaping and influencing models of commissioning, shaping and influencing models of legal literacy, so people in communities know and understand the language. And you missed my comment earlier. In terms of the government making this bill accessible, use a language that is accessible, because people won't understand it.
Thank you. And this kind of leads on to the last question. Barbara, am I okay to move on to the last question?
If we sort of roll the questions together of what steps can be taken to ensure the success of health and care partnerships, and then if anything anybody wants to add. Is that what you were going to?
Yeah, no, and it was also just the last one about how, because I think it leads on from what Maris was saying, is how do we ensure that the voice of patients and service users are heard? If anyone had anything to add to Maris's points as well.
Yeah, I should say we're into about the last 6 minutes now, so I guess I'm coming to you all now for your last thoughts on all of this. But particularly, what can we do to ensure the success of health and care partnerships, and that point that Sarah's just put about ensuring the voice of parents and service users is heard? So, Mary.
I think, yeah, just very quickly, I think it's about, I mean, Caroline's raised some important issues about people who've done a lot of work in this area, and I think, in terms of expertise, speak to them. But there is something very much about that requirement being set out. So it being really clear that that happens, and at what stage of the journey does that happen, and who leads on it. And someone within this process, or a group of people within the process, have responsibility to ensuring that the voices are heard, because there is a risk that it's the same voices that are heard, or it's people who already have a voice who are heard. And the important thing here is to hear the voice of people who are currently not having their voice heard, and who have felt disempowered over years. So there's something about empowerment, which certainly speaks to us as part of our core social work values, but there is something about really setting out that requirement rather than an expectation. So what terminology is being used, and it's not just a box that's being ticked. This is the golden thread that needs to run through how service partnerships are being formed, services are designed, and communities are heard. So that would be my initial thoughts.
Caroline, shall I come to you now?
Yeah, thank you. I'm just going to follow on really from Mary, and there are a number. So working with mental health time for action, for example, it's very much a patient-led, a people-led campaign group, if you like, calling out for mental health services to be inclusive of all voices. And I think from my perspective, it's also about, and maybe this is something that social work is, as Mary mentioned, in terms of our professional values, is that the profession that I'm in, we seem to be more readily available to engage with messiness, so engage with the difficult conversation. It is really difficult to meet people, and we have lived experience in the room, but it's really difficult to go to somebody with a lived experience of a service with the expectation they make the solution, or they're asked once and we move on. So I think what I would certainly encourage is, as Mary said, the breadth of voice. Go to the leaders, and there are so many leaders. We have such an active community in terms of finding solutions already, but also to feel less uncomfortable with engaging with the messiness of it.
Thank you. And Peter?
Yeah, I was just trying to think about whose voices that we have been struggling with to make sure are heard. And one of our recent concerns has been people who are what are known as self-funders. They often don't engage with social care insofar as they don't get assessments, they don't have eligibility determinations, they don't have help from social workers in devising care and support plans. They often make their own decisions, sometimes good, sometimes poor. And those are people, even though they are people who are financially better off, they are people whose voices within social care are not being fully heard.
Thank you. And Maris, we're in our last couple of moments. If you just give us your final thoughts.
Integration is not new. I think when it works well, it's really exciting, and it can only be good both for citizens and for leaders and staff, the workforce across the board. What I would say, my strong message is about system leadership. Leaders have got to be brave. We've got to work together, and we've got to make sure that there was parity and equity of funding across health and social care.
I think that message about funding has come out very strongly at so many points, but also points about culture, I think, have been important today. Well, we've got 2 more sessions in our inquiry in September, where we'll hear from organisations representing the users of social care and the social care workforce. So let me thank our panel, Maris, Mary, Caroline and Pete. I think it's been great the way you've, as a panel, you've kicked off our inquiry with your evidence today, and I really value your input, and I think it is timely. I hope we're not browbeaten into doing everything too quickly, as we've said in this session, but I think we've made a super start there, so thank you very much. And thank you, Sarah, for joining us. Thank you.